Steve.
Thanks. So just to be clear, I'm going to bookend the day a bit like we started with a Steve and we sort of finished with a Steve, and notwithstanding the fact Philip will say some words at the end. I'm the one with the V that's spelt correctly. He's the one with the long and eminent career. And he's done far more impressive things than I'll ever do. This is the title that I was given for today's talk. What I'm going to do is take the perspective of, given all the recent changes to governance in Victoria, all of the reviews that you've heard about today, I'm going to touch on those and see what does that now look like for the private sector. A lot of those changes have gone on, and I think we've been on a strong journey towards that end. And I think we've got a pretty good example. Epworth has 1,400 beds across 9 different sites. We do babies all the way through to geriatrics with intensive care neuroscience in the middle. So we cover a whole range. We've got a little day hospital, we've got a big tertiary hospital in Richmond, we've got Geelong, we've got Box Hill. So there's a pretty good example in there. We've got some mid-size, some big. So I think it gives a pretty reasonable perspective of where we're at. 2 years ago, I came and spoke at this very podium. It was a discussion about quality monitoring and the private hospital perspective. This was my last slide, not this exact slide, but these exact words. Private is different but the same. I left that with the message, and I can start again today at exactly that point. And I think I could almost stop there and say that's exactly where we're at. We got the national standards. They apply to us just exactly as they same do to the public sector. We have the same information sources. We have clinical registries. We've got VASM. We've got coded data. We've got Riskman. All of that stuff's the same. Safer Care Victoria has a role with us. The Agency for Healthcare Information has a role, which I'll talk more about in a little while. But I guess that we have an overarching funder. The thing is we have multiple funders, so I guess we start to see some of the difference. Multiple health funds all have a different view. Their role is ever increasing. They're starting to move from the quantity to the quality question. They're starting to try and define treatment by guidelines. So things are starting to shift. We're largely visiting specialists in the medical workforce. So rather than having an employed workforce, we have a visiting workforce, and that creates its own tensions and opportunities. I think it gives you a lot of flexibility and agility, but at the same time, you work via influence. So this is what I was going to talk about today, is trying to put all of that, so the review that was undertaken, the journey towards target zero, what does that look like in the private sector? I'm going to go a little bit back to where Stephen went earlier, and some of the other speakers have gone in between. The initial scope of the review was to look at the public and private sector. It was to look at the scope of reporting, the information flow. So this was spelled out right from the very first piece. There was no sort of making a difference. There was no differentiation. It was including those things. So it's about systems in healthcare. It's about reporting. It's about information flows. Now, when the report was published, that initial report, the Target Zero report, which I guess is where we get our title today, they carried the scope through very clearly there. The wording around it, I've just did the quick word search looking for any of those things. There's 145 mentions of private, and it's 27, not 25, in the recommendations that are clearly applicable to the private sector. They were broken up as applicable or not, or maybe. Executive summary alone, there's 28 mentions. So I think we're pretty clear message there that what has in the past been a pretty soft touch approach to the private sector is going to change. This came out of the report. This was the statement, and it's sort of covering off on what I just said. It's very clearly the department has a responsibility around private sector. In the past, that's been about registration, are your sinks far enough from the bed and close enough to the door, and the room's the right size, and some system-based, but really it's a little bit about, are your buildings the right size and can you get through doors? It's very clear there's no routine reporting around clinical outcomes. Sentinel events were never a mandatory thing for us to report, and really nothing else flowed except for a VAD component. That statement at the bottom out of the recommendations that all hospitals should be held to account for improving safety and quality regardless of their size or sector. So you're starting to see the messages now, very clear from the review group. So these are the recommendations that sit within it. Bear with me, we'll get off the report stuff very soon. The statements start becoming very clear that there's a common set of performance indicators across all hospitals. That hospitals be subject to the same reporting requirements as public hospitals. This is a very new field. We've had none of this before. Comfortable with it, but none of it's existed. There's been a lot of discussion over the years. Productivity Commission's had a look and made some judgment calls about the two sectors. National Health Performance Authority said they would, haven't. My hospital's invited privates to be part of it. What in effect you've got on there is a hospital profile, SAB and hand hygiene, and there's nothing else that comes for us to report. Waiting times are not really relevant. Emergency department targets don't apply, so off we go. So they're the reports. So you're starting to get a very clear message there. So as I said earlier, there's 27 explicitly related or recommendations that are explicitly applicable to the... Geez, I put some words together you should never put in a presentation. Never put explicit and applicable in the same sentence. If I talked about explicitly applicable statistics, that's actually pretty good. There are only 9 that say no, but there are 28 that don't make a statement, so I guess you can assume they're at some level applicable. Very clear, very strong message. The initial government response said, "We will also ensure public and private hospitals are held to the same standards and reporting requirements." Seems pretty reasonable. That was the first response back in 2016, October. So the 2 structural bodies we've heard about, Safer Care, we haven't talked about VAHI today. This is their strategic plan released in December last year. So to support all health services, to provide advice to respond to serious quality concerns about, to review. Now, we've never had review done before. There is something in the Act that says, if required, the Secretary can mandate. I don't think that happens all that often. I guess that would require a big event for that to be happening. And to review performance in conjunction with the department. So I guess there's we're starting to see a really clear message, and the different but same is becoming more same. VAHI, likewise, corporate plan, October last year. Their mission, we monitor and report on public and private. And then they have, within their initiatives for this year, this current financial year, is to develop measures to benchmark the performance of those sectors, across the whole sector. So now we actually have a look particularly about the sector, and I'm going to talk about it from my experience. So we see some of the, you could probably say, differences rather than challenges there. The question we often get asked is, it's interesting, we're running 2 different slide sets here to there, which means I've done something fancy last night that I forgot to tell Claudia about. You've got to ask the question about who owns the patient. We've had this discussion over the time. I've been now at Epworth for 8.5 years, and there's been a massive journey from, it's my patient that I bring to you, that you provide service for, and then I take it away and it's my patient. Don't you tell me how to provide care for it. I use that word deliberately. We are now moving towards a shared ownership, and in fact ownership not being the case and the patient being the centre. We're now using patient experience, patient-centred, patient satisfaction, but patient-centred is right there. Our strategic diagram has a whole bunch of circles working from community in, and the patient is the middle. Who is the customer? Well, 8.5 years ago, the doctor was the customer, and it was described to me by a very senior person of the organisation. I like to think of our organisation as a brewery, and the doctors are the pubs. No one drinks beer unless there's a pub, so we've got to take care of the pubs. I'm very pleased to say that's no longer the case. We now like to take care of the patrons who are arriving to drink their beer, as well as the people who are serving the beer from down the tap and out of the bottles. In conducting what we might call clinical governance or any of these other activities, I've been asked the question, and it's far less frequent now, but I've certainly been asked the question, well, what right do you assess my performance? How dare you? Who are you and what you? I've had that phone call at 6 o'clock on a Friday night when I sent out a report. Someone rang me who I'd never met and said, I don't know who you are, but I don't know what right you think you dare to have to. It was a very interesting discussion. After an hour and a half on the phone, while my family was inside at a restaurant, we came to a landing where there was an understanding on both sides. The lady who I was speaking to was far more receptive and understood I was just providing her with information. She says, how dare you collect this? I said, this is information I've got. What I'm doing is telling you that I've got it. And you can tell me if it's right or wrong. I'm happy to have that conversation with you. But it is a tension that does exist. So I call it a challenge. I call it a difference. And health funds I've touched on briefly. Their influence across the sector is growing perpetually. You've seen over the last few years the Medibank versus the rest of the world newspaper articles that were published by a number of different hospitals. We certainly had that experience. We weren't just quite as public as everybody else. Now the exciting bit where I don't know what's coming next. I'm now going to talk off here. So locally, in terms of addressing all of these things, there's a whole bunch of activity going on. We collect KPIs exactly like everybody else does. They're all colour-coded, which is a shame it's not a picture, to match the National Standards colour scheme. We'll change from the 10 to the 8 when the 8 come. We'll move our KPIs there. Our board sees all of that, our executive, our quality committees all see exactly that. So I think that's something that's just the same. We conduct routine audit across most of our specialties. We have between 40 and 50 orthopaedic surgeons sit in a room until 10 o'clock at night arguing different cases that are put before them. I find the cases, they go through a surgical filter and then we put them up. I'm incredibly proud of the fact that room sits there and they stay till 10 o'clock at night once a quarter. I can't believe it. And they get into each other. Why did you use that wire? Why didn't you cable it? Why? That looks a bit short to me. There's a fracture there. Didn't you see that fracture? And as a result, we have some nice outcomes, like our approach to anterior hip replacement surgery is now changing for the better. What we identified was we had the same rate of periprosthetic fracture around that approach, anterior versus the other approaches, but we weren't recognising the fractures till after. Therefore, there's a return to theatre, there's a revision. If you find it at the time, it can be addressed at the time and dealt with. So now we've got a whole bunch of initiatives going on led by our surgical population. We found the information, we took it back to them and said, well, you guys have got to work it out. I can sit here and tell you what I think, but hey, I was an intensive care nurse a long time ago. I'm not an orthopaedic surgeon. How about you actually come with a solution? That's one of the things we're putting in place. We're making changes, so it's really good. We're part of 13 clinical quality registries. It's an important thing for us. So, you know, we're on a really big journey to make sure all of that information is available. Some of the information we've shared publicly on the internet, and we share it very widely with internally. One of the roles I see very important for me is I've got access to every registry report and I make sure that the right people see it and I spread it far and wide internally. We've established a set of 11 clinical institutes. There's a list of those here on my piece of paper, so they're all very impressive. Pretty sure they're not coming down the stream. That'll be exciting if I get there. That brings together all of our specialists with our senior managers, and they're responsible for delivering audit, for stimulating research and education. They are more or less mature depending on the specialty. Orthopaedics, cardiac, critical care are awesome. Some of the other groups are. The ones who are more rooms-based care are struggling a little bit to work out exactly where they fit, but we're on our journey there. As of this month, we're putting together our first ever organisational performance report. So historically, we have reported on infections and patient satisfaction and death by cardiac, by that hospital, by that hospital. It's now in one place because I think one hospital who gets 65% for everything, individually we go, oh, there's 65, that's okay. But if you get 65 for everything, you know, I'd say, gee, there's a whole organisation issue here. If one gets 30% for something, but it's 90 for everything else, we clearly focus on the 30. We go, hey, everything else looks great. Now we can really hit. So it helps targeting the effort. This is all part of our new clinical governance structure that's come from a full restructure we've undergone through last year. That we've now we brought all of we had medical and non-medical kind of floating as two separate groups. We're now very clearly together, which is, I think, has been a really big step forward, but was a major gap we had before. This is the first time we put it all in one place. So we're trying to leap ahead a little bit of the requirements that are coming down the line. I'm sure they're coming. Let's be ready for them. In terms of undertaking this, I think a lot of these statements go without saying. Let's establish trust. Let's be clear about what it is. It's not a witch hunt. Let's work together on things. Let's put systems in place so there's less argument. The same thing gets applied to every person. So we have an all patients, all doctors, all campuses, all wards approach. You're in unless you try and opt out, and then the opt-out is the place for the discussion. So if everything's routine, they go, why are you discussing my case and not their case? You know, well, we discuss cases as they come up. We have a set of flags in place, so we look at returns to theatre, readmissions, death, long stay, ICU. Unplanned would be great. We're not quite there yet. The intensive care world's trying to help us get there. We're not quite there yet. Infections, craft group related complications. So it's a standardised approach. If we make it standard, it's harder to argue it. Write down what you're doing so everyone's clear about what it is. We're getting better and better and better at that, and I've just written down a couple of those things, and I've seen Liz Lewis here somewhere in the room who heads up our neuroscience M&M, retired neurosurgeon. She's keeping us honest. Oh, there she is, hiding in the back there. So we've, as a result of some feedback from people like Liz, we're actually able to move ourselves forward. Use the carrot and the stick. There's CPD attached to attending these events. There's bylaws that say you must. There's lots of other things there. Let's try and make it easy. Do it as easily as possible. I try not to apply burden anywhere I can, and ask what's relevant. There's no point, I can sit there and tell you what I think is important, but I've got to have the conversation and ask. So bringing it all together, I'm going back to my first slide. I'm going to say private's pretty much the same, but a little bit different. I could have almost stopped at that first slide, but I think we're all on the same journey. The messages coming out of all of those reports that I put up on the screen are that they said private and public, and then all hospitals and sector. As you start to bring it together and go, it's about healthcare for Victorians, we should all be doing that together. I think I've covered off on those next 3 points pretty comfortably. Work together, make it relevant to the people who are involved. No point someone from, head office sitting there and telling you what's important. Actually have a conversation with the people and just make it part of everyday business. That's all we're trying to do. And now we'll find out if there's anything coming after this. No. So that's what I plan to talk about today. I think that's your message. We're the same, but a little bit different. And we're ready and welcome all those, those new things coming down the line, because I think giving us benchmarking opportunities makes things so much easier. Thank you.